Good morning, everyone. Thank you for joining me today. We're tackling cardiac tamponade, a swift and silent killer where fluid around the heart chokes off filling, plunging patients into obstructive shock. Tamponade arises from trauma, think a stab wound, or catastrophic ruptures like a free-wall MI tear or aortic dissection spilling blood into the pericardium. Malignancy or uremia can fill the sac more slowly, and pericarditis complications sometimes catch us off guard. Remember Beck's Triad: hypotension, jugular venous distension, muffled heart sounds, though you may not see all three. Tachycardia and an exaggerated drop in systolic pressure on inspiration, Pulsus Paradoxus, are key clues. Our clinical radar must be sharp. In any hypotensive trauma patient or someone known to have a large effusion, look for rapid, shallow breathing, elevated jugular veins, and distant heart sounds. Test Pulsus Paradoxus by measuring blood pressure slowly. Inspiration should drop systolic pressure by more than 10 mmHg if tamponade is present. But nothing beats point-of-care echo. Within seconds, we can see a dark stripe around the heart, right atrial collapse in late diastole, and right ventricular collapse in early diastole. A plethoric IVC that barely changes with breathing seals the diagnosis. If the patient is unstable and you see these signs, don't wait. Drain the fluid immediately. In parallel, an ECG might show electrical alternans, QRS amplitudes swinging back and forth, and globally low voltages. Chest X-ray in subacute cases reveals a classic water bottle silhouette, though in acute trauma, the heart may still look normal. In the ICU, invasive monitoring demonstrates equal diastolic pressures across chambers, but in the ED, we rely on our exam and echo. Always distinguish tamponade from tension pneumothorax. Their breath sounds vanish and the trachea shifts, or from massive PE, which dilates the right ventricle instead of compressing it. Definitive care is pericardiocentesis. Under ultrasound guidance, we approach subxiphoid or parasternal with a long needle, aspirating fluid until blood pressure and cardiac output improve. In trauma or free-wall rupture, we may go straight to an ED thoracotomy or surgical pericardial window. No time to waste. While preparing for drainage, boost preload with IV fluids, but steer clear of diuretics or vasodilators that would worsen hypotension. Use norepinephrine if pressures are critically low. Oxygen is a simple but vital bridge, and in a patient near arrest, sometimes you pericardiocent first. Confirmation can follow. Always hunt for the underlying culprit. Aortic dissection demands surgical repair. Malignant or uremic effusions require drainage plus oncology or dialysis. Bacterial pericarditis needs targeted antibiotics, and post-infarction ruptures must be patched surgically. Pericardiocentesis buys you time, but definitive repair saves lives. After drainage, these patients need ICU care with continuous hemodynamic monitoring. Keep the pericardial catheter in place until output dries up, and send fluid for cytology and culture if the cause wasn't trauma. Repeat echocardiograms ensure we're not chasing a reaccumulating effusion. All tamponade patients belong in the ICU. Those with traumatic or dissecting causes will almost always need surgery. Malignancy-related cases may recur, often requiring a surgical window or sclerosis. Uremic tamponade usually resolves with dialysis. Before discharge, ensure the patient and their cardiologist have a follow-up echo scheduled, and teach the patient to recognize return signs, dyspnea, chest fullness, lightheadedness, so they seek help without delay. Cardiac tamponade is the ultimate race against time. Rapid bedside ultrasound, decisive pericardiocentesis, and targeted definitive care are the keys to turning a dire situation into a story of survival. Thank you. Let's discuss any questions or share your experiences managing this critical emergency.